Good morning, and welcome to the third installment in our webinar series on the Mental Health Parity and Addiction Equity Act, or MHPAEA for short. With the final regulations recently issued, there's a lot of work to be done to make sure your company is in compliance. And I know it's open enrollment season. You and your team, if you're lucky enough to have a team, are already juggling a lot of things. You've got benefit plan updates, employee questions, and more. But here's the thing. The Department of Labor has made mental health parity audits one of its top priorities. As Yoda would say, do or do not. There is no try. No matter how busy you are, you must take time to follow the rules or risk costly penalties later. Hi, I'm Jennifer Austin, Senior Director of Strategic Marketing and Employer Engagement here at the Alliance. In our first two webinar sessions, we covered the fundamentals of the Mental Health Parity and Addiction Equity Act and discussed the proposed regulations. The goal was to give you a solid foundation for understanding the legislation and how it relates to your business. If you missed those sessions or would like to revisit the content, you can watch them on demand by visiting the Alliance events page or our YouTube channel. Links to the recordings are also provided in the resources box on your screen. Today, we'll be diving into the final regulations released in mid-September this year by the U.S. Departments of Health and Human Services and the Treasury. They have two key deadlines. The first takes effect in 2025, while the second takes effect in 2026. We want to make sure you understand what these regulations mean and what actions you need to take now to prepare. By staying informed, you're also supporting a more inclusive and equitable approach to mental health care. Now, before we get started, I want to take a moment to make sure you're comfortable with our newer webinar platform. For those of you joining us live, you can resize or close all the boxes, including the video screen and slides. There's also a chat box and an emoji button. We want this to be engaging and fun, because what says fun more than new regulations? And most of all, we want to make sure it's easy for you to view today's content. Please use the chat feature to ask your questions, and we'll answer as many as we can at the end of today's program. We've also developed a handout of the slides to help you follow along and take notes during the presentation. In our previous two installments on this topic, we also provided a flyer to help you promote employee well-being within your organization. For your convenience, we're making this document available again. You can download all the handouts directly from the resources box on your screen. Finally, since there's a lot of material to cover in today's session, the recorded video of this event will be made available for on-demand viewing from the events page on our website and via our YouTube channel. We'll email a link to all attendees next week when it's available. And last but certainly not least, I want to take just a moment to thank Delta Dental and National Cooperative RX for their ongoing support. We truly appreciate it. It enables us to continue bringing these valuable programs to you, our employers and partners. As we begin, I want to re-emphasize that as an employer, you play a pivotal role in the mental health and well-being of your workforce. The Mental Health Parity and Addiction Equity Act, or MHPAEA, is a federal law requiring health insurance plans to extend equal coverage for mental health and substance abuse services. That means mental health benefits should stand on equal footing with traditional medical benefits you offer your employees. Our focus today, however, extends beyond the mere legal obligations. Our goal is to help you adopt a proactive mindset so you're prepared when these final regulations take effect. Think of the next hour as an investment in both the well-being of your workforce and the long-term prosperity of your business. Today, I'd like to welcome back John Barlament, one of our most popular webinar presenters, to remind us what the Mental Health Parity and Addiction Act is, why it matters, and what you need to know to ensure you're in compliance with these final regulations. John is an employee benefits attorney who works with employers and health plan vendors on various legal issues with a focus on health and welfare plans. He has extensive experience in mental health parity matters and frequently presents on an array of employee benefits topics. He is recognized as a national leader in these changing areas of law and has been interviewed by and quoted in leading publications like the Wall Street Journal. Welcome, John.
All right, thanks, Jennifer, and thanks everyone for being here today. We do have a pretty full agenda in terms of our topics today. We're going to start off with some basic information, kind of defining key terms or maybe refreshing your recollection of them. We'll talk about kind of the core requirements of MHPAEA. We'll talk about the QTL, quantitative treatment limitation rules. Not going to spend a lot of time on the QTL rules because those have been around for a long time, to be blunt, and that's not the new exciting stuff here. The new and exciting stuff is the new NQTL, non-quantitative treatment limitation rules. There's a new two-part test. There's an expanded comparative analysis which applies, and we'll also offer some practical advice. And as Jennifer referred to, this looming deadline here is going to come up very fast. The first batch of these new NQTL rules applies for plan year starting January 1, 2025. So if you have a calendar year plan, which is a pretty typical plan, that'd be 1/1/2025, about a month and a half away. The other piece will be effective January 1 for plan year starting January 1, 2026. So again, we have a little bit more breathing room on that piece of it. In terms of kind of the defined terms, the ABCs here, we're not going to go through each of them. Mental Health Parity, MHPAEA, the Affordable Care Act, Consolidated Appropriations Act, CAA. That's really what is driving us here today are some CAA changes that were passed in December of 2020. And we're still just kind of working through them here. MHSUD, mental health, substance use disorder benefits, MS, medical, surgical, and again, some other defined terms there. In terms of how we got here, why are we dealing with this law? Well, MHPAEA was passed because there was a congressional belief that health plans, both fully insured and self-funded, were not treating mental health benefits and later substance use disorder benefits fairly. So again, we have a couple legislative changes over the years. We have various regulations over the years. And when I talk about treating them fairly, I'm talking about comparing them to medical surgical benefits. Basically, this whole test is we put into one bucket, into one category, all the medical surgical benefits. We put into a second bucket or a second category, all the mental health benefits or substance use disorder benefits. And we kind of compare the two to figure out if we're treating them in a non-discriminatory manner, basically. The plans that are subject to these rules generally apply to group health plans, typically major medical plans, accepted benefits like most health FSAs, dental, vision, generally excluded. So again, think of it as mainly applying to your major medical plan. No exemption for church plans, so church plans are subject to it. There is an important exception for small plans or retiree-only plans. Definition of small is a little bit confusing. Generally, if the employer had at least 2 but not more than 50 employees on business days during the preceding year, then you're going to be small. There is a situation where that number could bump up to 100 in some situations, so it's a little bit confusing. And it's interesting. Most of the time, fully insured plans historically have not worried about this rule, but we do have some clients who are right around 50 employees, have a fully insured plan. Later on, we're going to talk about a fiduciary certification rule that, at least as of right now, seems to apply to fully insured plans. So, even if you are 50 employees and fully insured, you may think the insurer is handling all this. As of right now, there is a piece of this that you have to handle yourself. It's going to be very burdensome for a small 50 or 60 employee company, but as of right now, that is a risk out there. There is an increased cost exception, which is possible but difficult. There used to be an option for self-funded non-federal governmental plans to opt out. That has been phased out. MHPAEA overview here. MHPAEA establishes 3 main requirements. So let's walk through the first couple very quickly so we can spend more time with the more important NQTL ones. Annual and lifetime limits. If a plan has annual or lifetime dollar limits for medical surgical benefits, must apply those same or higher dollar limits for mental health. So $1 million lifetime limit on medical surgical, $500,000 lifetime limit on mental health would be problematic under these rules. People don't really structure their plans this way anymore because the Affordable Care Act basically said you can't do this with respect to essential health benefits. So in theory, you could do it with respect to non-essential health benefits. Most clients, most employers don't really try to distinguish like that. So, so again, this one is interesting, but kind of a historical relic. This one, potentially more applicable, financial requirements and quantitative treatment limitations like visit limits cannot be more restrictive. Hold on, Jennifer, I'm having an issue where I went to slide 13 and then it kind of bounced me back to 12, but we'll see if it does it again here. So again, financial requirements can't be more restrictive against mental health benefits compared to medical surgical benefits, and there can't be separate cost sharing requirements only for mental health. So we've had this situation pop up where an employer might draft a plan saying that there's a $1,000 deductible for medical surgical benefits and a $500 deductible for mental health substance use disorder benefits. It looks like you're treating mental health better because it's got a lower deductible, but because it's a different separate deductible, that violates MHPAEA. So again, if you have a plan like that, you should look at it and try to take out that kind of provision. A couple of slides here on the QTL rules. Again, QTL has been around for a while now, I don't know, 10 years or so. If you haven't done a QTL test, by the way, you probably should do a QTL test. This is a pure numbers crunching test. You look at financial requirements like co-payments, co-insurance. You make sure that they apply to at least 2/3 of the medical surgical benefits in the classification. If they don't, then you can't impose those co-payment or co-insurance requirements on mental health benefits in that classification. So again, kind of crunch those numbers to pass the first part of that test. If you meet that 2/3 test, then you have to check and see if there's a single level that applies to more than half of the medical surgical benefits. If no, you kind of aggregate them until you get to more than half, 50.01%. If yes, then you use that limit for mental health or substance use disorder benefits. The net takeaway, by the way, for this is that you can end up with what I call super parity, where mental health benefits get treated better. They may have a different co-insurance or co-payment amounts than medical surgical benefits. So it's just purely mathematical. Again, if you haven't run that test, you should run the test. That's a very good idea. All right, let's change gears and talk about the more important pressing deadline, which is NQTLs. What are non-quantitative treatment limitations? Well, NQTLs are kind of non-numeric limits on the scope or duration of benefits for treatment. And every single health plan has NQTLs. It's not illegal to have NQTLs. Your plan, I'm sure, has NQTLs. Every plan has NQTLs. So just wanted to set the baseline here. In terms of the NQTLs, what are we talking about here? We're talking about typical plan designs to kind of control costs. So every plan that I've ever seen has some kind of medical necessity requirement. We're only going to pay for procedures if they're medically necessary, or experimental limitations or investigational limitations, things like that. So very, very common to have that sort of limitation under your plan. Formulary designs for prescription drugs, network tier designs, maybe other ones might include standards for provider admission to participate in a network. And again, some of these are kind of behind the scenes, right? Most employers don't know what your TPA or network provider is doing in terms of insurance requirements. But usually those network building entities go to different doctors and say, hey, we have various standards you need to satisfy, certain insurance limitations, certain minimum amounts, things like that. So again, a lot of this is kind of behind the scenes where employers don't really know how this is going on here. And again, the fact that it's going on is not abnormal. It's completely normal. But the question is, behind the scenes, sort of, is it going on in a way which disfavors mental health or substance use disorder benefits? Other ones, prior authorization. If you had a situation where you impose prior authorization requirements on every single mental health benefit, but no medical surgical benefits, you'd be treating them very differently. That would be a very clear NQTL problem. Usual, customary, reasonable, figuring out how much we pay for things, step therapies, exclusions based on a failure to complete a course of treatment, et cetera. One thing that the industry had asked the U.S. Department of Labor to do was to provide a complete list of NQTLs, or at least the ones that they have seen, because one of the things that the DOL wants you or your vendor on your behalf to do is to identify the different NQTLs in your plan document. And so it would be helpful if we could obtain clarification from the DOL about what NQTLs it's seen, and then we could kind of take that back and try to look at it. However, in the new September regulations, the DOL declined to do that, basically. So again, just puts a little bit more pressure on employers and your vendors to adequately identify different NQTLs. And by the way, for what it's worth, I have had disputes with TPAs about whether certain things are NQTLs. There's a well-known big insurer slash TPA that is kind of aggressive about one particular item that I think is an NQTL and they think is not. So again, you can run into kind of disputes about what is an NQTL. In terms of this slide, as if you've listened to me before, you know I usually throw a lot of words up there. I don't usually put a lot of images in. This is my one image here because I think it conveys it pretty accurately in terms of the risk. The main risk with NQTLs is what I call the below the water risk. And the below the water risk is the different practices and policies and procedures and administration that your TPAs, PBMs, network vendors, telehealth vendors, others do kind of behind the scenes, something that employers would not normally know about. I just gave you the example on the previous slide about insurance requirements. Many mental health professionals operate on kind of a shoestring budget, if you will, where they may have a very small office that's just a one-person office compared to a giant hospital that has the financial wherewithal to have higher insurance limits. And again, if your TPA or network vendor is kind of picking on healthcare professionals by requiring very high insurance limitations, again, that's a below the water kind of thing. Employers would not know about it. It kind of goes unseen unless you press them for additional details on it. The above the water piece is easier. That's the piece that we can all see. That would be your summary plan description. So taking a look at your SPD, trying to find little glitchy things in there that maybe look like they're picking on mental health benefits is kind of the easy piece of it. The harder, more complex, more difficult piece is the below the water stuff. So we think that employers likely will put pressure on your vendors to try to verify if they're complying sort of behind the scenes. All right. Let's jump into the new September 2024 regulation. So what did they do? They had a new two-part test and expanded on what a comparative analysis must include. So new two-part NQTL test. Plan cannot impose an NQTL with respect to mental health, substance use disorder benefits. In any classification, there's different classifications like, in-network, out-of-network, emergency, things like that. That is more restrictive as written or in operation than the predominant NQTL that applies to substantial medical surgical benefits in the same classification. If the plan fails to meet these two things, the design and application rules or the required use of outcomes data rules. What are those? Well, let's start with the first one, the design and application rule. Any processes, strategies, evidentiary standards, or other factors used in applying the NQTL to mental health benefits within a classification have to be comparable to and applied not more stringently than the processes used in applying the NQTL to medical surgical benefits. That is a lot of words, but what it basically means is whatever processes are being used by the TPA or the PBM can't pick on mental health benefits. And let me give you an example of sort of picking on mental health benefits. This is from a lawsuit from a couple of years ago where a leading vendor in this space out in, I think it was California, wanted to develop procedures, policies about, I think it was how long eating disorder benefits would be pre-approved. So if someone has an eating disorder and they go to a residential facility, let's suppose that there's 5 leading guidance documents out there, and that 4 of the 5 say that should be pre-approved for, say, 30 days. But one of the 5 says that it should only be pre-approved for, say, 10 days. What this vendor was doing, allegedly, was going through those 5 guidance documents, finding the ones where it could kind of cherry pick the standards which were worse for plan enrollees, and then using that. So if you just ask this vendor, hey, what guidance documents do you use to figure out how often to or how long to pre-approve something, they'd give you 5 documents. They all look like good, independent, third-party, official kind of resources. But the cherry picking, where they kind of picked and chose the lesser standards, again, was a process where they were kind of violating the rules sort of behind the scenes. So it's getting to that level of depth of, okay, vendor, how are you figuring out these things? That's kind of what's now expected in terms of, again, the depth of what you need to delve into. So that's going to be difficult, right? It's going to be challenging for an employer to know that and to ask the right questions. Other points here: the definition of what is mental health must follow current ICD or DSM guidance. Those are kind of medical standards. Plans cannot rely upon any discriminatory factors or evidentiary standards starting in 1/1/2026. What do we mean by discriminatory standards? Well, a standard is going to be discriminatory if it's biased or not objective against mental health benefits. How do we figure that out? Well, facts and circumstances test. So we have to kind of look at it and make some judgments based upon the reliability of the information, the independence of the information, the methodologies used to select the information, how consistently it's applied. And to pause for a second here, this is going to be difficult. I've talked to some TPA and PBM clients about it. This is going to be a challenge for them here, this second bullet point, because they may use particular procedures to figure out whether something is medically necessary. They may have developed those procedures 5, 10, 20, 30, 40, 50 years ago. The people who came up with those procedures may be long since retired. And so the current TPA folks may have no idea why this particular methodology was implemented, 10 or 20 years ago. Now they're going to kind of have to go back and sort of recreate the wheel and figure out, okay, why do we do this? Why, what's the basis for it? So it's going to be more work. And again, I think that mainly is going to fall on the TPAs and PBMs. But as the plan sponsors, as the fiduciaries, the employers need to kind of oversee that whole process. Historical information from a time when the plan was not in compliance with MHPAEA is biased if it systematically disfavors access to mental health benefits. My next bullet point is kind of tongue-in-cheek, maybe snarky, maybe is the right word. But if almost all plans are not in compliance today, does that mean that no one can use any historical information? What do I mean by that? The U.S. Department of Labor has said that in a couple of reports to Congress that in the first year, everybody failed. In the second year, nearly everybody failed. Perhaps everybody failed. We don't know for sure. So in other words, the DOL has looked at various comparative analyses. They've never been happy with anything. They think every big insurer, every big TPA, every big employer, they continue to say, no, that's not sufficient. So we don't know what they are looking for exactly. They won't give us an example of a good analysis, but we just know that the bar keeps getting raised higher, basically. There is a safe harbor for fraud, waste, and abuse standards. I think that most TPAs will probably satisfy that. Required use of data outcomes. So this is a 1/1/2026 rule. What does it say? Plans have to collect and evaluate relevant data in a manner reasonably designed to assess the impact of the NQTL on relevant outcomes related to access to mental health or substance use disorder benefits, and carefully consider the impact. So again, it's some kind of data collection rule. As I'll talk about in a slide or so, we don't quite know the details of it, but we know that it's looming in 2026, which will mean that we'll need to do things in 2025 to get ready for 2026. You can't disregard relevant outcomes data that the plan knows or reasonably should know suggest the NQTL is associated with material differences in access to mental health benefits compared to medical surgical benefits. Let me pause for a second here. Note the squishy term. Squishy is not a legal term. That's my term. Associated with, access. What do these terms really mean? We don't know for sure. The proposed regulations from the DOL last year would have provided kind of a numerical test. And if you pass the test, you passed. There's nothing more to think about. The industry pushed back and said, we really don't like that. We think it's going to lead to some adverse results. And so the DOL kind of dropped the mathematical test, and now they've moved to squishier black and white, the squishier non-black and white, facts and circumstances kind of tests. So, it was probably a pick your poison kind of situation, and this is what we ended up with again, kind of squishier terms, for better or for worse. In terms of what is relevant data, we don't know. So we have to collect it. We know we need it for 1/1/2026, but we don't know what that is yet. We will get further guidance on that. The DOL has promised to update their self-compliance tool, which is basically out of date right now. They've promised that they may get out an additional kind of standalone document on the required data. So we're not quite sure what we're going to need. The regulations note that the data could include, as appropriate, but not be limited to, the number and percentage of claim denials. So number and percentage of claim denials, let's say that, you say, okay, prior authorization is an NQTL. We need to know how often mental health claims were denied for prior authorization versus medical surgical claims were denied for prior authorization. That absolutely could be one of the data points that we are going to have to ask, employers are going to have to ask their vendors to provide to them. I could really see that being true. Again, we don't know that for sure. We will get more data on that, but that's going to be, I think, important. Other data relevant to NQTLs required by state law or private accreditation standards. This one's kind of a weird one because in the ERISA context, the self-funded ERISA covered plan context, we normally ignore state laws. We don't really care about state laws. ERISA preempts state laws in general. Private accreditation standards, we don't really care. There is no private accreditation standard for an ERISA covered group health plan. But your TPAs, your PBMs may try to comply with private accreditation standards. They may comply with state laws that apply in the fully insured side of things. So you may kind of lean on those is perhaps what's going to happen. Again, we don't know that for sure. So I think it's a good question to maybe talk to your TPAs and PBMs about. But that's one that, again, we don't quite have thorough guidance on yet. All right, for network composition, this is the NQTL where the DOL is concerned that maybe the networks are not robust enough. Maybe we don't have enough mental health providers compared to medical surgical providers. And so they're saying, employers, you need to gather data to verify if your network is good enough. What could the relevant data include? In-network and out-network utilization rates, including data related to provider claim submissions. Network adequacy metrics. Many TPAs and insurers have the capability to do kind of a geolocation analysis. They can plot where your plan enrollees live and verify if there's enough physicians who are located near them, so you can kind of figure out if the network is adequate enough. Provider reimbursement rates for comparable services and as benched to a reference standard. So again, the concept is, are you underpaying your mental health providers? What if the data is unavailable? Well, if it's a new NQTL and it's just temporarily unavailable, you need to explain that. If the data could never exist, there's certain categories we think could probably just never exist because they never really get processed. It just kind of gets denied. Again, you're going to have to document that, or again, lean on your TPA to document that. What if the data exists and the plan, the TPA, PBM runs the data, but the data suggests that the NQTL leads to worse, my word, outcomes from mental health benefits. In that case, you have reached the flow chart, the decision chart point where you have to take some action. If the data suggests that the NQTLs contributed to material differences in access to the mental health benefits, it's a strong indicator that the plan violates the MHPAEA. At that point, the plan must take reasonable action to address the material differences to ensure compliance. In addition, you, as the employer, have to document the actions that have been or are being taken by the plan to address those differences. So this is an action point. If in 2025, when you get the data, when you run the data, if you reach this point, you're going to have to document, okay, we identified a problem here, and here's the steps that we took to mitigate the issue. One legal question that we don't quite know is, at what standards do we need to act? The regulation says that if the data suggests that an NQTL is likely to have a negative impact on access to mental health benefits, you have to act. But again, those are very squishy terms to me. Suggests, what's the definition of suggests? Likely, what's likely? Negative impact, what's negative impact? For example, is negative impact a 50% difference? That sounds like a lot. I think you'd have to act. What if it's a 0.01% difference? That doesn't sound like much. Technically, it's a negative impact, but do you really have to act if it's 1/100th of a 1%? I don't know. I hope not. But again, these are kind of squishy, kind of gray terms. And I could see employers being very conservative initially when we don't quite know what the DOL is going to be looking for. We do expect that employers are going to ask their TPAs, PBMs to kind of crunch these numbers, give them the results, and then act upon that. Network composition, again, some special rules here. Plans have to collect and evaluate the relevant data designed to assess aggregate impact of those NQTLs and access to mental health benefits. What to do if the plan identifies issues? There are some examples in the regulations. For example, you may want to strengthen efforts to recruit and encourage a broad range of mental health providers to join your network. How would you do that? One thing that the regulation suggests is that employers can increase the compensation that you pay those mental health providers. That to me raises the question, how much more is that going to cost employers if we have to suddenly open up the checkbook here and start paying mental health providers more? I don't know. I haven't seen a number yet from a consultant about will that increase cost by 1/10 of 1% or 2%, 5%, 10%? I don't know. So I think there probably could be a cost in that situation. But again, hopefully we don't get to that point. Hopefully you don't identify a weakness, if you will. Other things, streamline the credentialing process, contact other network providers, ask them to join. Again, those are kind of behind the scenes things that your TPA or network vendor would typically be doing. Other special rules related to network composition. You can consider expanding telehealth. I think this is a really helpful guidance here. A number of employers have started using telehealth, and there are vendors who offer it in the mental health space. So again, really helpful, maybe a good way of kind of dealing with network adequacy issues. You could also potentially help enrollees find in-network providers and ensure that provider directories are accurate and reliable. Your vendor should be doing that anyways, but there are some concerns about what are called ghost providers, where doctors are listed as being in the network, but they're either not accepting new patients or maybe they just aren't actually in the network. So they've left, but the vendor hasn't updated its database yet. A couple other quick points here. You can't have separate NQTLs that are applicable only with respect to mental health benefits. You probably would have guessed that was right. If you only applied prior authorizations to mental health, you never applied it on the medical surgical side, probably kind of intuitive to everybody that would be problematic. Each NQTL must comply with the plan as written and in operation. Again, kind of a general rule there too. All right, I'm just gonna pause for 1 second and see if there were any pressing questions. I know we're gonna take questions at the end, but Jennifer?
Yeah, we did receive a question in the chat Tanya had said, I want to send an email to our TPA asking them if our plans are compliant in regard to mental health parity. How would I phrase that question?
Yeah. So, I mean, starting off with that is probably a good way of framing it initially. Most TPAs are not going to respond, yeah, you're good. You're 100% compliant, because this burden is technically on the employer, the plan sponsor. Um, Most TPAs that I've worked with are willing to get you 80% of the way there, 90% of the way there. They're willing to put together NQTL template documents and say, this is how we process your claims. This is how we figure out who's in the network, things like that. But employer, you may have some of your own processes that vary. You may have directed us to do weird things for you in the past. You control the SPD. We don't control the SPD. So normally they're willing to get you 80% to 90% of the way there. And so I think you could certainly ask them, can you get us that far, and then we can take the rest. Maybe that'll change. Maybe TPAs are now willing to provide a legal certification. I kind of doubt that, because just in general, TPAs don't provide legal advice. They don't want to be like the fiduciary here. So I think starting with the basic question, gathering their documents, gets you 80% of the way there. I hope that helped. All right, moving ahead to the comparative analysis piece. So again, that was the two-part rule, comparative analysis. What is this? CAA requires that every self-funded group health plan put together a written comparative analysis detailing how the plan complies with these rules, that it doesn't impose NQTLs more stringently on mental health benefits. So this is basically a 6-step process. We weren't quite sure what to do when the CAA got enacted in December 2020. April 2021 FAQs provided us more guidance on exactly what is going to be needed. And again, kind of a 6-step process here. The 2024 regulations really expand upon those 6 steps. So it's kind of still a 6-step process. If you've ever seen one of these template NQTL comparative analyses documents from your TPA or PBM, and again, the really big ones all have it. The mid-sized TPAs tend to have it. The smaller TPAs, it can be hit or miss in terms of whether they have it or not. But if you're dealing with one of the big ones, you've probably seen this kind of template document. And what does it normally do? Well, in the 2021 guidance, it said we have to identify the NQTL. That makes sense. 2024 regulations goes beyond it. You have to describe the NQTL. You have to put in the specific terms of the plan that have that NQTL. You have to identify all mental health and substance use benefits to which the NQTL applies, and which benefits are in which classification. So a little bit more of an expansion there. Again, specific terms of plan. I mean, I think we now need to actually say, here's where medical necessity is in the SPD. It's on page 42, and it's on page 56, and it's on page 71, and do that on a NQTL by NQTL basis. So I think we need a little bit more detail rather than just saying, we have a medical necessity requirement. Now I think we need to say, okay, and here's what sections of the plan it's actually in. Step 2, identify the factors considered in the design of the NQTL. That's the 2021 guidance. 2024, identify and define the factors and the evidentiary standards used to design and apply it. Every factor considered or relied upon, and you have to define each factor. Again, let's pause for a second there. That can be challenging for TPAs. As I talked about, some of these TPAs developed their medical necessity guidelines 20 years ago. Those people who designed those factors that they considered, those people are gone. And so the TPA or PBM may have to kind of recreate from scratch. Okay, why do we do this? How does this process work? So again, as employers, you're not going to know. You're going to have to press the TPA for this. And I think the big TPAs are working on this kind of update already. Define the factors. In 2026, take if there's any factors which are biased, describe what you're doing there in terms of fixing it. Number 3, identify the sources, including any processes, strategies, or evidentiary standards used to define the factors. Here, number 3, a little bit different again. Describe how the factors are used in the design and application. Detailed explanation of how each factor is used to determine if the NQTL applies to the benefit. If the application of a factor depends upon specific decisions, nature of those decisions, who makes those decisions, things like that. Special rules if there's more than one factor kind of competing. You also have to identify any deviations or variations from a factor or its applicability. Again, employers are not going to know that. If your TPA kind of deviates or has some kind of unusual feature in how it processes a claim, you're not going to know that as a practical matter. So you're going to have to dig into this. Number 4, are the processes comparable to and no more stringently applied to mental health benefits in 2021 and 2024? Demonstration of comparability and stringency as written. So again, now we're going to have to get into more of the data requirements. Like I threw out that example of, how often are prior authorizations approved for mental health benefits compared to how often are they approved for medical surgical benefits. Records maintained by the plan, including the consideration of all these different factors for each classification, compare how the NQTL is designed and applied, including specific provisions of any forms, checklists, procedure manuals, or other documentation. Again, that's the kind of behind the scenes documentation that your TPA or PBM may have. Those are kind of instructions to its workforce. When you're processing these claims, how do you kind of process them? Number 4, continued documentation describing how the factors are comparably applied to determine which benefits are subject to the NQTL, explain the reasons for any deviations or variations, including in the definition of the factors. Again, a lot more detailed in 2024 than what we had in 2021, and a lot of those details are things that only your vendors would know. And even they may not know it today because, again, they may just be kind of on autopilot, for lack of a better term, following procedures which were developed a long time ago. Number 5, comparability in operation. So a little bit unclear in terms of what the 2021 guidance was. 2024 regs really expand it and say, again, you need a comprehensive explanation of how the plan evaluates whether in operation these processes are comparable to and applied not more stringently than the ones that apply for medical surgical. Explain any methodology or any underlying data used to demonstrate this, the sample periods, inputs used in any calculations, definitions of terms used, any criteria that are used. Again, real kind of behind the scenes type of data and definitions and processes and things like that. If the data is temporarily unavailable, explain why the data is not available. And again, this is a 2026 rule. For data for which no data could ever be obtained, again, kind of write it down and explain why. Document the outcomes of it and provide kind of a reason, justification for any differences in the data that maybe are not material. So kind of explain it away if you can. Other details here. 5H, a detailed explanation of any material differences in access. Again, kind of explain the issues if there are problems here. And then under I, discuss the actions you take to address any material differences. Again, if your network is inadequate, how do you beef up that network? Did you offer to pay the providers 5% more? Something like that. So again, this is going to be important to kind of work through all of those issues there. And then once you've done those first 5 steps, now you have to reach a conclusion. So they want, the DOL wants somebody, a plan fiduciary, to kind of say, hey, we looked at this, we feel comfortable with this, we believe that we are in compliance, or maybe you conclude that you're not in compliance. And if you're not in compliance, what are you going to do about it? Again, they're looking for that kind of analysis. They're looking for the date that the analysis was completed, the title and credentials of the relevant person who participated in it, or the relevant people. If you use an expert, what are the qualifications of that expert? Again, just a lot more detailed here in terms of what they're looking for. All right, let me pause again. Jennifer, well, first of all, do we know, did anyone jump off a bridge when I went through those things? I don't know if we have any reports of fatalities here. Hopefully not.
No, not seeing that. Seeing steady numbers, but no additional questions came in other than the ones that were submitted prior to the start of the webinar.
Okay, sounds good. Excellent. Be safe, everyone. So in terms of the next couple things here, so meaningful benefits, and again, we'll get through this. I think TPAs and PBMs and employers we'll get through this here. Next one is meaningful benefits. Meaningful benefits. What are we talking about here? The regulations say that if a plan provides any benefits for mental health in a classification, the plan has to provide meaningful benefits for the treatment of that condition or disorder in each classification. It would be problematic if a plan provided for a range of medical surgical benefits, but only one limited benefit for mental health. What's going on here? Behind the scenes, what I think is going on here is the DOL has found situations where employers maybe cover a very modest benefit, like they'll cover the diagnosis of autism. But in terms of actually treating the autism, we cover nothing. That I think is driving the DOL crazy. And they feel like that is a real kind of violation of these rules, the spirit of the rules. And so this is saying, no, you can't do that anymore. You can't just say, well, we cover the diagnosis, but we don't cover any treatment. If you're going to cover it at all, then you have to kind of cover it in full is what they're saying. The third bullet point, I think, raises the practical question of who's going to comb through all the benefits under your plan and identify which benefits are not meaningful. So is that going to be a TPA issue? Is it a PBM issue? Is it an employer issue? My guess is that for 1/1/2026, that employers are going to lean on their TPAs to help them identify this, or maybe consultants, or maybe attorneys. I don't know, but I'm not quite sure how it'll shake out. But I think the industry is going to have to kind of delve into it a little bit more. It does raise a question for me at the bottom. What if the employer does not want to cover some services? We have some clients who, for example, have concerns about like gender dysphoria treatment or gender reassignment surgeries, or limitations on that. And so, I could see these regulations as being interpreted as, hey, if you pay for someone to get diagnosed for gender dysphoria, but then if you don't cover the surgery, are you really providing meaningful benefits? We'll see. We'll also see if the Trump administration maybe takes a different approach than the Biden administration or Harris administration would have taken in terms of enforcement here. All right, fiduciary certification. This is a brand new requirement. This is a 1/1/2025 deadline, so this is a little bit more urgent. For plans which are subject to ERISA, a plan fiduciary is going to be required to certify in writing that they believe a prudent process was used and that they selected a qualified service provider to perform and document the comparative analysis. So, you have to kind of prove that you hired somebody who seems competent, seems good, that you walk through their analysis. You could ask questions, you could poke at it, and then make sure that you understand the findings and the conclusions. Who can be a qualified service provider? Unclear. Recent webinar, DOL attorney said there's flexibility on this. There's no certification for this, position, if you will. So I think it is kind of open there. I do think that law firms like ours are getting involved in this. I know that some consultants will get involved in this. Maybe actuaries. I don't know. So we'll see probably a variety of different folks. But the net takeaway is that it's going to put a lot of personal pressure on the plan fiduciaries to ensure that everything is legally correct. Again, if you are signing on the dotted line as a plan fiduciary, and remember, ERISA's fiduciary duty rules are the highest known under law, is what some courts have said. So really kind of the highest standard out there. It's going to put a lot of pressure, personal pressure on plan fiduciaries, I think, here. Unclear how employers with fully insured plans will address this. Again, they are potentially, under the current rules, subject to this. DOL enforcement. So what if we just say, you know what, John, that sounded pretty awful. Let's just ignore it. Well, unfortunately, there are enforcement mechanisms here. If the DOL finds that parity has been violated or that comparative analysis is not provided or incomplete, the plan is going to have 45 days to take corrective action. After 45 days, if the DOL finds that the plan is still in violation, the plan must notify enrolled participants of the non-compliance within 7 business days. So you're confessing your sins. There's standard language, 14-point kind of big font. Attention, HHS has determined the plan is not in compliance with MHPAEA. I mean, that's bad from a HR or employee relations perspective. I think you're also perhaps inviting private lawsuits, right? If you've kind of confessed that you violate the rules, it makes it probably pretty easy for plaintiffs' lawyers to try to come up with some way to bring a lawsuit there. Plan participants can ask for a copy of this written comparative analysis. It's covered by ERISA, so you have to respond very quickly to it. We've talked to some clients about potentially using attorney-client privilege to help shield some of the unfavorable findings if we're helping with that comparative analysis. Might help, might work. I don't know if there's any case law on it specifically in this context. The DOL must provide an annual report naming the plans in violation, so kind of a name and shame type of approach. DOL can refer violations to the IRS, which can assess civil penalties of up to $100 per day per affected individual. DOL could bring a lawsuit and could try to actually prohibit the use of an NQTL. That one worries me actually quite a bit because if they say, your medical necessity determinations are not in compliance, does that mean that you can no longer have a medical necessity determination? If you're experimental and investigational, no longer in compliance, does that mean you can't have experimental limitations? That could be expensive if we suddenly can't deny non-medically necessary treatments. Other practical considerations, TPAs, PBMs, employers that don't have anything are going to have to kind of work here quickly. That 1/1/2025 deadline is looming. There is a chance, I think, that the new Trump administration could try to repeal the regulations. Congress could intervene here. I don't know that it's high on their list. Traditionally, mental health regulations have had bipartisan support, both Republicans and Democrats. But I could see that, how stringent some of these rules are, that that there could be a pushback here. So it's possible that at some point in 2025, we will get some relief. The problem, of course, is that if you have a calendar year plan, you're supposed to be compliant by 1/1/2025. So you can't necessarily bank on that, I guess. Other takeaways, employers should ask vendors for updated comparative analyses, those kind of template NQTL documents. What if they won't have them finalized by the first plan years that starts 1/1/2025? By the way, I think that's probably likely. There's a lot of stuff in here. And so I think there's probably going to be a period where, employers reach out in writing to their vendors and say, hey, we want you to help out with X, Y, Z. And the TPAs are like, yeah, we know that, we're working on it, but it may not be done by 1/1/2025. I could absolutely foresee a situation where, many folks are still working in the first quarter of 2025 to have everything documented back to 1/1/2025, if you will. I think that that's likely in the real world. What else? Tough for anyone to know what data will be required at this point. Will TPAs crunch the numbers? Will they charge for it? If you are an employer working with a TPA and PBM, should you ask them to do that right now? Should you get into your contract? Probably a good idea to do that. When will the DOL tell us what data is needed? We're not sure. The American Benefits Council and kind of a different coalition of different groups sent a letter on October 24th saying that guidance is needed by 12/31/2024 for the data requirements, or we're going to need like an extra year of good faith relief because they say basically that TPAs and PBMs will probably need a year to develop the required data reports. Note that there is no good faith relief available yet. So in theory, on January 1, 2025, for every calendar year plan, the DOL could swing into action and start, bringing penalties, bringing claims, bringing lawsuits. I don't think that that's likely. I think they want to see effort as a practical matter. They want to see diligence, kind of your fiduciary process being followed. I think you got to do something. But cost to do the work, interestingly, in the preamble to the regulations, the DOL estimates an employer's cost at $50,000 to $150,000 per plan. I actually think that that's probably a little high. But if you haven't done anything, if your TPA won't help you, and if your PBM won't help you, it becomes a lot more expensive, I think. TPA's cost to develop these procedures, DOL estimates at $200,000 to $300,000, just to kind of come up with those template documents. That, from some of the ones that I've seen, that's actually probably low. Some of them are, 200 pages long, 150 pages long. I can't imagine the number of, hours that went into them. So if you were charging hourly rates for everybody, I think it's probably more than 300,000, really, for the TPA side of things. Attorneys, including our law firm, do this work. We have a number of employers who use the same TPA or PPM. When they do that, we can split the cost of reviewing that vendor's comparative analysis. So let's suppose that 5 clients ask us to review several ABC TPAs and QTLs, and the cost is $30,000. We would divide that $30,000 cost by 5, so each employer would pay $6,000 for that review, if you will. Some pieces can never be divided. Employers' unique SPD, everyone should be looked at for these kinds of issues. Those vary from client to client, so we can't really do anything there. My contact information is at the bottom in case you want to talk about that more. All right, Jennifer, let's kick it back over to you. Questions?
Yeah, we have quite a few questions, but I know we're running a little short on time. So I will just start with Emily. Is there an instance when an employee can sue us for wrong advice that is well intended? I think of it similar to CPR training. And is there a good Samaritan law in place to protect the employer providing the employee aid?
Yeah, so good questions. In general, there's no specific kind of good faith relief. I referred to, there is no good faith relief here. And the DOL made it pretty clear that this process is subject to the fiduciary rules of ERISA. And again, fiduciary rules of ERISA, highest standards known under law. So the DOL really wants you to be wearing your expert hat when you answer questions. So I would just, kind of advise employers to be careful here, act in good faith, but read up on it, understand it. Yeah.
I'm going to ask one more question from Alicia. What are the penalties for not complying with the NQTL testing requirements versus not conducting the test at all?
Yeah, and we covered this a little bit on the previous slide. So again, there are some theoretical monetary penalties. The DOL issued a compliance report last year where they noted, I think they penalized 3 different employers with monetary dollar amounts. And so their monetary dollar amounts are possible. I'm actually a little more nervous about the thought of an NQTL disappearing and not being in your quiver of arrows. If you can't impose medical necessity, if you can't impose prior authorization requirements, I worry about the cost to the plan. That could be millions of dollars perhaps in extra claims. So I'm a little more nervous on that side, if you will.
Great. I'm sorry. I know we got some more questions in, but we're running short on time. Thank you so much, John. I just really appreciate you taking the time to share your knowledge on this really important topic with us today.
Sure. You bet. Happy to help.
And if you need additional resources, please reach out to your account executive here at the Alliance. We have experience in benefit plan design, and we're happy to assist you. And if you're not a member and are interested in learning more, please use the QR code or URL on the screen. As I mentioned at the beginning of this webinar, we've created a flyer to help promote employee well-being within your organization. You can download that by clicking on the link in the resources box. And if you have any difficulty downloading anything, please just email events@the-alliance.org and we'll happily get a copy to you. If you're watching this webinar live, you can claim CE credit by clicking on the View Certificate button on your screen. If you don't see the button, click and drag the box on your screen to make it bigger. And finally, we'd love to see you in person. Stop by and say hello if you're attending any of our upcoming trade shows. And be sure to save the date for our spring symposium in Madison on April 23rd. Thank you so much for joining us today. And remember, when you think of the Alliance, think self funding smart. Take care.